You can bill anything, but having it paid is a different story.
In dentistry, we're often taught to document what we did, not necessarily why we did it. Did your medical insurance cover it? No, the dental office said, no, this is dental in nature. I said, come on under your lunch hour. Let's just call your plan. 75% coverage, implants, abutments, crown, pre-op pano, post-op pano, guide, the entire diagnosis was covered. We're going to code what we did, why we did it, and if it's covered benefit, it is.
And we are back with another edition of Nobody Told Me That. And I have, oh my gosh, a very long-time friend, Leslie Icenogle, is here from Insurance Billing Outsourcing and Dental Classroom. You've been busy lately.
Yes.
So hi, how are you? How's everything going?
Fine, thank you.
I'm glad you're on. It's been a long time coming. So, people are getting more and more into medical billing, and Leslie is one of my resources for medical billing for sure, because as many of you in my classes know, I will say, don't call me on medical billing. I'll have you do it wrong. You'll never get reimbursement. And there's a couple people that I do put up on the slides. Christine Taxon is one. We both know Christine. We both know Delane Glogie. And Leslie, you're the other one too. So I want to talk a lot about medical billing, Medicare, a little bit of Medicare Advantage. And I think all wrapped up into that is documentation, right? Like that's, oof, right?
That
you and I have a lot
correct.
of talks about documentation.
Yes, and I think that the biggest shift there in documentation mindset is in dentistry, we're often taught to document what we did, not necessarily why we did it. In fact, coded for trauma for years, and doctors put AA, automobile accident, when in fact with medical billing, we need to know, are they a passenger, what type of a vehicle, etc. So you're correct, Teresa, as usual, it's documentation. Make sure you document, even if we involve the patient and have them fill out an accident form. But yes, documentation is key.
Honestly, there should be like a billboard up the state of documentation in dentistry, and it's just like fail. Like, maybe we move towards getting better, but usually it's fail.
Yeah.
So
surgery, and with oral surgery, you have to document for hospitals. So I did a lot of transcription back in the day when they needed us to do that.
Wow.
And so the documentation part of it is different for the hospital than it is for most dental practices. So that's where the oral and maxillofacial surgeons get a little extra training on the SOAP, subjective, objective assessment and plans. But I think it's becoming the norm now, Teresa. We're seeing a lot more of the SOAP notes in dentistry.
I hope so. I definitely, diagnosis is something that still we have a hard time kind of carrying that over from the initial evaluation, right? But it's so important, especially with medical billing. Now, I remember when I first started speaking for the this is a mouthful, and this is where I met you, Leslie, the International Congress of Oral Implantologists. The auxiliary section was called the Association of Dental Implant Auxiliaries, so ADIA. And Leslie and I were both speakers for the ADIA, and that's how we met a long time ago. But I remember Lynn Mortilla. She's been married since, but to me, she's always Lynn Mortilla. But she was a mentor for me, and I owe her a lot for getting my career started. But I remember she said, it was my very first speaking gig, and she said, can you talk on insurance for implants? And I said, oh, yeah, I can. And then she said, okay, well, we need something on medical too. And I said, oh, no. And it was my very first. And she said, okay, we'll talk about the dental implant codes, which I think back then we had 5.
Right.
Then she said, well, what about medical? And I said, okay, I'll put up a slide, but that's it. And I remember thinking then, I hope nobody ever calls me for this, because the research I did just to create those 2 slides was enough, right? But then I remember you started coming in and you started speaking on medical billing. And between you and Christine, I realized I have no idea what I'm doing. So what do you remember from those early days of medical billing for implants? Do you remember we had 2 codes, and there was 1 CPT code that we could use pretty much. So what do you remember from those days?
Oh, well, first of all, it has changed since then, and really for the better, because I think that was 2010 that we started speaking. It's been a long time. A couple of the big new advances that have been helpful, and if you have any knowledge of medical billing, there's really 2 sets of procedure codes. There's the CPT, the current procedure terminology, and then there's the HCPCS, which is really the void of codes that are not in the CPT codes. And the D codes, our ADA's, D codes, were added as HCPCS codes about 5 years or 6 years ago. That has been huge because medical payers can, look at a D code and say, okay, this is a HCPCS code, and they'll have a definition of what that is. So that was one of the big advancements. The next advancement is one that you're well aware of and may have already spoken about, is Medicare allowing dental claim forms to be submitted electronically as long as they have the diagnosis codes, the ICD-10, in July of 2024. So first of all, that's a big wow moment that the oral systemic link is getting more recognized by physicians. I know I've seen you post some articles about that and some physicians that are talking about it. And I think those two big things have really helped our industry. I used to have a harder time back when I started in oral surgery communicating the procedure to payers, where now it's okay, well, if I put the D7240, then they know the degree of difficulty of the extraction. So since we did this back in 2010, there's been some real wins. And then there's been some more confusion too. So we can talk about that as well.
Oh, yeah. There's always confusion when it comes to just coding in general, but then the complexity of medical billing. And so I encourage any of you who are thinking that this could add profitability to your office, go slowly, because getting involved with the government is always something to be aware of. And, medical billing in and of itself is medical billing, but medical billing with Medicare is a totally different animal. We'll talk a little bit about that. And before anybody starts asking Google for HCPCS, it's HCPCS, right?
Yes.
And it's not actually HICS and PICS. Because I remember starting out, I would hear HCPCS, and I'm like, what is a HIC? I don't know these things. So so there's lots of acronyms. Oh my gosh, the acronyms that we have to know.
In my classes, I have an entire segment on Medicare acronyms. Because it's like you talk a different language when you call them, right?
Oh, you're not kidding. You're not kidding. So I know that when it comes to medical billing, I always operated under, okay, if there's an accident or there's trauma, and then I learned about implant billing, then I started to learn more about oral surgery billing. But there's even more procedures that are, like, as you said, and I love this, you can bill anything, but having it paid is a different story. But you really have explored and done well in the sleep apnea world too. So talk to me a little bit about how that's exploded in dentistry.
Well, first of all, warning to the offices that are adding sleep services is there is a mandatory filing act with Medicare for procedures that they cover. For instance, your sleep apnea appliances. So if you get trained clinically, for a new service that could be considered medical in nature, then we really need to train our admin team too on what, we want to stay compliant, right? We have all of our other things in place. Well, medical billing, unfortunately, I know that some of us would like to say that it wasn't true, but it's in our field. And when you have a mandatory filing act like Medicare has for sleep services, then you could have a $2,000 violation, and it's really not a difficult subject to learn because there's only so many codes for those. You usually have your initial evaluation, no sequence of, radiographs and sleep studies. You have your appliance and your follow-ups. It's not that difficult, but just knowing what forms need to be signed. So the two I warn people on there, Teresa, is, if you're an in or even a non-par doctor for Medicare and you find, okay, this patient does have sleep apnea. That is a diagnosis that Medicare covers, great. But if they just have symptoms like snoring or insomnia, and you do not have by a sleep study that actual diagnosis, then we have to have them sign the advanced beneficiary notice, the ABN, saying in a lot of cases this is covered, but in your case it probably is not going to be. Flip side of the coin, if you've opted out, then you need to go into a private contract with that patient, notifying them, I've opted out of Medicare. So they have a decision to go to a Medicare Part doc if they would like. So that's where my warning would be there, is the mandatory filing lags. But what we often see coverage, it's kind of black and white what's covered, and then there's the gray areas. What is typically covered is any, trauma or injury, congenital defect, whether that's replacing, congenitally missing teeth, or you may have a frenectomy, soft tissue procedure. Then your oral and facial pain disorders like your TMJ and things like that. So there's, your systematic conditions is where we're seeing a little bit more coverage. But then the gray areas are the implants that we were talking about. Why was that tooth lost? Was it the natural aging, or was it trauma or injury or a birth defect?
Yeah, so if it's from perio and they were going to lose a tooth anyways, but if they get into a bar fight and get hit in the mouth with a bottle, that actually gets covered, right? Because it's an
Exactly,
accident. It's so
exactly.
funny. I remember that was a specific example from a class I took a long time
Yeah, and
ago.
periodontal disease is something that they're really considering more coverage on because
It's good
of
to know.
the inflammation and the medical conditions that are linked to that disease.
Hmm.
So, and another thing that I always forget to point out is if a patient doesn't have a dental plan, they often have a dental writer embedded into their medical plan. So
Okay.
when I was in oral surgery, I would always say, "Do you have insurance?" And I remember one lady standing out, just I still see her. She said, "Oh no, I just have medical insurance." I said, "Well, let's file it. All they can do is say no. I mean, the teeth are impacted."
Yeah.
And so sure enough, I was in the grocery store a few months later and this lady came running up to me and gave me a big hug and said, "I know you. You're the girl that got me a $1,900 check in the mail,
Oh my
medical
gosh.
insurance paid." And that was back in the late 80s. So I'm sure it would have been a lot higher now. But it
Yeah.
makes you feel really good when you
Oh
get
yeah.
patients' benefits are entitled to because they think, "Oh, I'm going to a dentist. I don't even think about filing my medical." When in
Oh, that's
fact,
great.
there could very well be some coverage for whether you're pregnant, you have prophies for that visit or
Hmm.
diabetic. There might be some more, dental coverage in those medical plans.
So you're a third party billing company, insurance billing outsourcing. When you're bringing on a client, do you now tell them to see about getting medical insurance as well as dental insurance information?
Yes.
Now that's part of your intake.
It is, and actually, you should be copying, I would think, any type of provider of the medical and dental insurance card for a
Okay.
couple of reasons. Because dental may request a medical denial, and then you have to contact that patient and get a hold of it. But you are going to, soon learn that there are more plans that are covering dental work because in another cases, and I won't go into the full details, but a lady was having digestive issues, went through digestive surgery. Her physician finally said, "Hey, let's go see the dentist,"
Hmm.
and reconstructed her mouth and everything like that. She had no digestive issues after that. She
Yes.
was not properly masking her food.
Yeah.
So it had been cheaper for the insurance or less costly to fix the problem in the first stage of the digestive system than to wait till it went through the entire system.
Yeah.
So, if it saves them money, they're going to perk up and say, "Hey, let's do this right. Let's solve the problem, while it's in the first stage of the digestive system."
And I think too, that might have been something I learned from you a long time ago because I remember hearing that, if you have mastication problems, chewing problems, then, that is part of what is it, the alimentary canal, the digestive system, right? And
Mhm.
so you will, like you said, it's cheaper than to do an endoscopy and all that surgery and all that kind of stuff,
Mhm.
reflux pills for years, all that. But I remember you saying, reach out to, I'm sure it was you, reach out to the specialists that are involved in this and start having conversations with them. Because I do remember we did reach out to get GI doctors in the area to talk to them about this. And it was hit or miss with whomever we could talk to. Back then, though, a lot of physicians' offices were like, "Why are you calling us?" And so I think
Mhm.
now there would be a lot more conversation allowable for that. One of the better relationships we had was with IVF, and we didn't bill medical, but the relationship between low birth weight and infertility and perio disease was huge. And so we actually did have a really good relationship. So for any of you looking to maybe branch out and work more in the medical community, GI is perfect. Gastroenterology, cardio, bad disease, high blood pressure. And one thing I learned, I think from you too, is that when somebody doesn't have good chewing, they tend to eat very easy foods. And so their weight actually, that's
Mhm.
also a part of it too. So giving them the tools to actually eat better, instead of going for Cheetos that dissolve, now you can have like a carrot. I mean, I don't know. I have a hard
Exactly.
time with that, but you know what I mean. So
Exactly. Your food
yeah.
choices are limited. And I've had a Parkinson's disease gentleman that was choking on his food. He got
Mhm.
an all on, I believe it was all on four on the lower and all on six on the upper. And his was covered under medical because he was choking.
Wow.
So, yes, there are a lot of kind of those gray areas that you may have to spend a little extra time with a letter of medical necessity to communicate the why. But the truth of the matter is, my true passion has always been in implants. I love being able to give somebody something that they haven't been able to have. And
Hmm.
you'll go to any, whether it's a 4th of July party, a wedding, a shower, there's always food involved.
Yeah.
And it is super limiting to people that are denture wear as to what they can go. They'll go to the cake because they can
Hmm.
easily, eat that in public. And it is sad because that is, their overall health is being, impacted by their food choices. So you're
Yeah.
exactly right. Mhm.
Excellent, excellent conversation on that because I think when you realize like our whole social society is set up around usually celebrations, foods, gathering. And if you're embarrassed to chew and all that, you might be seen as grumpy when in reality, you're just nervous about if I chew this, it's going to hurt or my dentures are going to look loose. People are going to know. There's a whole psychology behind that. But let's back up a little bit, because for somebody listening who really hasn't done a lot of medical billing, one of the more confusing aspects, and I see this being asked all the time online, is you mentioned out of network. Okay, so you mentioned non-participating, opted out, and then of course participating. So what people, let me just do this and then let me just do a little talk and then I want you to make sure I said it right. Okay.
Mhm.
So Medicare Advantage, let's take that out of the equation. We're talking Medicare working with big medical bills and Medicare itself. A provider could have opted out, but then what they basically are is invisible to Medicare, right? So will they even process claims for that person or?
When you've opted out and you have to go into a private contract with the patient, so you have to do it properly, only
Yeah.
on covered procedures, not, oh, they're coming in for pro fee. But
Okay.
anyway, when you enter a private contract, then that's saying that you, the provider, nor the beneficiary are able to file a claim with Medicare.
Okay.
You can charge your entire fee. You're not automatically put into that category, though. You do have to go through the proper steps to do it properly. And so then, yes, your private contract, you're on your own fees. The Medicare in general, you can either be in network and you get 100% of the limiting fees, or you can go as non-par,
Okay.
which is where most dentists are thrown into automatically. And that means you still have to go by the limiting fee. And this is where the calculation, so I'm going to put it this way. Medicare will pay 95% of their limited fee.
Okay.
The non-par doctor is allowed to charge 115% of that. So it's like comes down to like a 9%, 9% difference when it all comes out. But you just have to do that little calculation. So you have to know where to find the limiting fee. You have to know what you can charge. So if I'm non-par, I am still limited on what I could charge a beneficiary.
Okay.
And if I feel that this procedure is normally covered, not like my pro fees, etc. There again, the sleep appliance was a good example. But in your case, it's not going to be because the diagnosis is just not there for them to cover it. And then I have to do the ABN, the Advanced Beneficiary Notice. So the goal of the government is to protect our senior citizens from outrageous healthcare bills. But we as providers don't like that Medicare word. It's scary because, like you said, it's a government. But we do have to know, okay, if I am really part of the mandatory filing law and I have to send this claim, I need to know. I need to do it properly the first time. And now that you can send a dental claim, it's really not that difficult. You just have to know the diagnosis in order to put on there, on that electronic claim.
And you have to know your status too, because I've run into a lot of offices that found out they were opted out because maybe an office manager in the past, it's every 2 years, right? Is that right?
Correct. And now it's auto. It used to not be. And that's why a lot don't know that providers they say, I don't know. What am I? It's because it's an automatic renewal now. Unless you notify them, they'll automatically keep you in the opt out.
So what if you're opted out and you miss that automatic renewal? Is it you're opted out for another 2 years?
You're going to be opted out for another 2 years.
There's no getting around that. Okay.
Correct.
Well, it is what it is. I mean, these are the rules we have to know.
Yeah.
So,
and, it's great if you can charge your entire fee. And that might be a great position for a lot of people. But do remember, you have to let the patient know and have them sign that you could go to a provider that is either par or non-par and get coverage. So,
and now, is it true that if you are opted out and you prescribe something to the patient, that would not be covered because they basically don't recognize you as a provider? Is that, I think I read that somewhere.
That for a while was a big buzz, but who got hurt by what that was the laboratories and the pharmacies, that you would prescribe to. And so you can prescribe. That's why you're kind of automatically thrown into that non-par situation, is so that you can be an ordering and clarifying physician, but it's not as what we did go through a few years ago. Yes. They're not going to cover the pharmacy end of it.
That was a big deal. I remember that. For some reason, I want to say it started in Ohio.
Yeah, and it kind of reminds me of the Medicare Advantage plans where they said, oh, well, if you're not in Medicare, then Delta or whoever is administering that claim isn't going to cover you. That was great for a couple of years.
Yeah, it was. Well,
then, it's the same.
Yeah. And so that's a good transition point. And I just want to make sure, because especially the people who are listening who are new to dental billing in general, this is totally Greek to them. So the dental billers see all the time is Medicare Advantage plans. All right. And so they're administered by dental billers. And if you opted out previously, this is the gray area that you were talking about. If you had opted out, then, oh my gosh, I can't even see my Delta patients and all that are, but that's not the case. The ADA, I think it was 2 years ago, I think they went to bat and made it so that CMS was like, no, you're fine for Medicare Advantage.
The newer to the dental field, the main part is those Delta Dentals or Aetnas or Cigna, whomever administer the Advantage plans, but it's still Medicare that's funding some of it.
Yes.
So that's where that Medicare Advantage has to at least have the same coverage as Medicare, period.
Mm-hmm.
So that, is where it got a little
crazy.
Uncertain.
Yeah. So you're doing business with Medicare by proxy, right? Through there. And the other piece is the whole fraud, waste, and abuse training,
exactly.
That I'm sure you cover in your class, because it's something that the whole dental industry is like, wait a second, what? So, I mean, we're required. I mean, if you're doing Medicare Advantage through Delta, United Healthcare, whatever, participating or not, that's now what we do. So, and we can talk about that on another podcast. That's like, I'll get a headache.
If you're thinking about what Medicare does cover is if a senior citizen falls and breaks their jaw or there's a laceration. So there's more they cover than just the sleep services. But yeah, that's.
Are you a dental biller feeling overwhelmed and isolated? I get it. The world of revenue cycle management is complex and ever-changing. That's why I created Dental Revenue Network. Our membership community was created to help you become a better revenue cycle manager and small business operator. Say goodbye to feeling alone and hello to a supportive community of dental billing professionals. Here's what you'll get: monthly billing focused meetings with peers and experts, business building sessions to elevate your career, resource libraries tailored for billers and billing company owners, introductions to cutting edge RCM technologies and companies, and a vibrant community for networking and support. Ready to transform your dental billing experience? Visit dentalrevenuenetwork.com today. Don't wait. Join us now and navigate the business of RCM with confidence.
Well, let's talk about regular medical billing. Medicare is its own animal, right? How different is it? So, for example, I know a lot of pediatricians now have hospital privileges. They now are billing to medical plans for the frenectomy, service early, very newborn services, right? So what is the process to get credentialed with a medical plan? Because the dental credentialing, that's by itself, is it similar? Is it totally different?
I think that's a great thing to bring up, because now when you come out of school for the last maybe 5 or 6 years, you know what CAQH is. ADA partnered with the CAQH. Oral and maxillofacial surgeons have been in CAQH for credentialing for years.
Right.
And that's how medical payers will credential you, is they're going to go to your CAQH. If you provide them your ID number for your CAQH, then that's where they're going to get your data. Now, when you sign up, you can say, give everybody my data, or you can pick and choose, and they'll email you and say, hey, Aetna Medical's wanting your data here, can we share that? But when you give them the CAQH ID number, almost all the medical plans will use that as the credentialing starting point.
Okay.
Still a little lengthy, 120, 180 days. In my classes, what I teach is, okay, let me get that ball rolling by, maybe I did a couple of cases. There's something that sparked my interest to take this course. Let's take those past courses or cases and file them so that we're getting you recognized. You're getting used to the software, and hopefully get that patient some money they weren't expecting, right?
Yeah.
But that credentialing process is easily done through CAQH. I think that their processes are very well designed to get you credentialed. One thing I hear a lot of is, well, I don't want to be contracted. They're two different words. Credential just means you're legitimate, not practicing out of a basement somewhere, and you upload your current liability insurance, your license, etc. So they're not asking the admin team for this information. It's in one portal for that reason. And then they will test regularly. They'll send you an email saying, hey, your dental license are expiring. Please upload, a new copy of that. So it's really the same. Since ADA did start working with CAQH, I don't think there's as many dental payers that are involved as there are medical payers.
For sure.
Now, Medicare, there again, you want the PCOs, the electronic, like you said, it's a different subject. But once I filed my first medical claim and I put on there my CAQH ID number, they may need a W-9 to pay you or whatever. But the most thing is, it's just going to take a little bit of time. So that's where a lot of practices may get discouraged. Like, my goodness, it takes me 3 months to get paid. And my cycle management isn't, that's not what we
Yeah.
want.
Yeah.
It's not true. Actually, medical is very, very quick, and they will
Yeah.
pay you interest automatically. I was just at the University of Michigan doing their sleep services on Medicare, and I brought up some EOBs, and I showed, look, 2-week turnaround. Frenectomy is usually a 1-week turnaround. Soft tissue biopsy, soft tissue is
Yeah.
about a 1 week. Usually your sleep and stuff's more like a 2 to 3 week turnaround for you to get paid. Initially, it's going to take a while. That's why I want to do some past cases. Let's get these under our belt.
The revenue cycle is different. And also, the medical plans, I think, are a lot more scrutinized than dental plans, obviously. So they actually have a lot of benchmarkings with real teeth to their fines, So I think that's a big reason too. But please let me know if I'm wrong on this. I'm guessing that the reason they're faster with it is because of those diagnosis codes, descriptors, and all of that. They're not asking for radiographs and chart notes and all of that. So that to me is very appealing, that I don't have to justify by sending in all of this stuff. So is that why the turnaround is quick? Because they're not really kicking it out to a consultant like the diagnosis codes. If it matches, it goes.
Yeah, I think you're exactly right. I mean, we've got your local coverage determination, your national coverage determination that states for this procedure code, these diagnoses are covered. Even in their plan descriptions, a lot of times they will outline what diagnosis codes are. So I think, yes, you hit the nail on the head. It's like, we don't only know what you did, why you did it, and those two are considered medically necessary, then they're paid. It does, the audit adjudication of it is just real. Now, there are some things like sleep services that we do need to communicate that we have that proper, but we communicate through a modifier. We'll put the modifier on that all the documentation that we need to provide that service has been obtained. So they communicate with modifiers. They communicate with what they call qualifiers, like are your teeth numbers, oral cavity, etc. So the one claim form is you usually can get it done on one claim form too. Let's say I did a full mouth extraction, to get somebody ready for an organ transplant. Now I'm filing this with medical. You can put, all of your 7120s on one line. And so you have like maybe 12 extractions. So what was a 2.5-page dental claim could be a 1-page medical claim that has modifiers, qualifiers, diagnosis, procedure codes, and it just tells the full story on one page.
Wow. Okay. So let me just do some vocabulary here for people. A diagnosis code is the same as a modifier?
A diagnosis code is the International Classification of Disease, ICD-10.
Okay.
If you love to play like I do, just go to icd10data.com.
Okay.
And it's really fun because you can put in there, snowmobile accident, and, it brings up an ICD-10 for it. Or you can put in caries, and there's several different degrees. And of course, there's the right way to use that too. Green is go, red is you need more specificity, which I hate that word. You need to get to a more specific reason.
Yep.
So the diagnosis is your ICD-10.
Okay.
And your qualifiers are like my teeth numbers. So let's say I removed 8 and 9 because of trauma. You do have a prefix of JP to put in front of it. But JP, 8 and 9, these are the teeth numbers. So you put in the qualifiers as more of the area of the oral cavity or the teeth. Your modifiers just further describe the procedure. So in sleep, in you is one that we have to use, like it's a new appliance. Or KX, hey, all of my documentation and my paperwork's received from the physician, the sleep study, etc. So we communicate a lot further. And I know, of course, ICD-10, what was it, 2012 claim form had rooms for ICD-10.
Yeah.
So that's not foreign if you take a government plan like Medicaid for your dental. A lot of times we have to put an ICD-10 on there. And I'll tell you what, Teresa, it sounds more difficult than it is. It's just a matter of putting your systems into place to where these diagnoses are captured at the evaluation.
Yeah.
The doctors are selecting them. Medical billing is, I feel, easier than dental because they have all those reasons you just mentioned. You've got everything they know what they're scrutinized on. They know they have to pay within 30 days. They know exactly what you've done without having to put a narrative or an x-ray involved. So.
It's so funny because I think you, me, and Christine, we've had this conversation over dinners, because you and Christine do love medical billing. You've said it's easier and I'm going, oh my gosh, it's not. But there was a time when anybody who's listening walked in and saw the dental codes and was like, I don't know what to do with this. And it's very similar. The medical codes the same way. My thing with medical billing is when you start moving into pre-authorizations and approval for services. It's a whole different ball of wax. So I think, yeah, honestly, it's very appealing to not have to send in those x-rays and use the diagnosis codes. And in fact, in the early years of me teaching dental billing, there was a code set of dental diagnostic codes, and they're still out there, but not really being used. And Dr. Mark Jerkovich in Minnesota, he's been spearheading this for a while, and I feel like he gets closer and closer every year. But I was talking about it from him about, I don't know, 12, 13 years ago, and it still hasn't come to pass. And I do think that that would have made life a lot easier, but I don't know if we're able to stick that in there now. But an example of that would be like caries into the nerve. Like the descriptor would have been like, here's caries and then mild, moderate to, severe. And so instead of having to attach the chart notes, we would have just said, this is how serious it is. And it did make sense to me for a while, but yeah, I just don't see that coming yet.
I really applaud his determination and his going into this, because SNODENT and all those different things are really meant for us to study, different areas. Why are there more caries in this area than others? Is it education, or is it their water, whatever? But I love ICD-10 in the fact that not only is it international, Canada uses the same code system, but it really does help us study the oral systemic link. And I've been to a lot of hygiene programs and stuff where it's really, really, okay, the oral systemic leak, the best way to study that is to say, this is why we did the procedure we did. Mm-hmm. And then we can quantify that a little bit better. Okay. Like, where do we need more education? In Indiana, we had an incident where there was an area that was having higher cancer, determination. It was something to do with an old plant in the soil, blah, blah, blah. But the ICD-10s will help say, okay, why is this zip code having way more of that diagnosis than elsewhere? So I think it's an important system, not just for payment, but for us to really study, how is periodontal disease affecting their overall health? How is diabetes affecting their oral health, or dry mouth, with the medication? So I think it's a smart system and it's easily adapted. Mm-hmm. What we have a problem with is having a software, even your oral surgery softwares, taking those 12 extractions and putting it down on one line, for the medical claim form. That's where we have a little bit of difficulty, but
changing the claim form is not an easy process. I'm learning that myself, but there will, I believe, and again, you, me, and a couple billers, we always have these conversations. I do think we're going to be wrapped up in medical fairly soon, maybe around the time I retire. Definitely might be the reason I retire, but there it is. So I know this will be exciting for you, but for me, I'll be like, oh, okay, Leslie, let me check in with you and see how you're doing, because you're killing it now. Yeah. But I do think it's coming. And if anything, I think the DSOs are really going to drive that, because they've already seen the impact of working with local health systems and all of that. The ones who are organized enough to do it. There's quite a few DSOs that couldn't be or quite organized yet. They're still getting their feet grounded. But that also entails changing software. I mean, you bring up software, and so that just kind of got me started. Like, do you see a time when Epic is in dental offices? Do you see that coming?
Yes, I have some providers that are already using it. Some of my, DMJ specialists, and those are already using Epic, because you can really communicate with the physician very well. And the software that we have now, though, is adaptable for sure. Okay. We have now the clearinghouses, there's hit and miss on which software you use there, but every one of the major ones you are able to create a medical claim form. But the days of sending in a paper claim have passed. We want auto adjudication. We want electronic submission. There's free stuff that is out there for us to do that even allows attachments. So in my dental classroom, those courses, Dental Classroom Online, is just basically like that. Here's some free resources. Maybe you do 5 sleep appliances a month. This is going to work out great for you. So it does tell you how to adapt software. And I apologize for coming up. For the most part, I always say, if I can do it, you can do it. The main thing is just getting to know the acronyms and the language and how to adapt your software to create that claim. There are so many similarities between the dental claim form and the medical claim form. They almost look identical as far as the top is the patient, information. The bottom, very, very bottom, is the provider. You want to make sure NPI 1 and 2 are in the right places. But just if your doctor's in CAQH and you have that identification number, then you're going to be able to get credentialed. That's the first hiccup that people usually have. And then the second one is making sure you use all the modifiers, qualifiers that are needed to tell the full story the first time. Do it right the first time. And, then have that conversation with the patient. If it is something in the gray area, like implants, go ahead and, either use a financial, group like Care Credit or somebody to help the patient pay for it. but say, hey, think of it as a gift if insurance pays. And then that way they're not expecting it and saying, hey, you told me this was going to be covered under my medical. That's how I like to start that conversation is we want it to be very positive. You want to get that hug in the grocery store like I got.
Yeah.
You
That's
don't want
a
it to
great story.
backfire.
Okay, so would you recommend then, because right now somebody might be saying, oh gosh, we don't build a medical, but what I usually get the frantic calls, and that's when I usually do the mass email to my 3 resources, here somebody needs your help, is okay, now we have to bill medical. And now they're like sitting there and there's a patient that's like expecting you to be ready. What can they do now to be ready for that first patient? Should they go ahead and get into the CAQH credentialing
Yes, and
system? I mean,
actually,
just get started with that?
this so many dental payers are going to the CAQH, and like
Okay.
I said, your new providers that come out of school, really for the last 4 years, are like, oh yeah, we got in CAQH as soon as we graduated.
Oh, yeah, yeah. I think at this point you should have one. I mean, I don't know why you wouldn't have an account. You
Unless you
wouldn't.
want to
So,
waste your administrative time and having them fill out that paperwork.
oh yeah, let's do that,
Well,
Leslie.
you have the No Surprise Act now too. The No Surprise Act makes, our payers keep their portals up to date of who's in
Yeah,
network and their office hours and things like that.
yeah.
So why tell several different payers and umbrellas when you can just go into CAQH and put that information? It is a time consuming thing to start. When
Hmm.
you get out of school, it's going to be an hour to an hour and a half. I always say, don't whine, just get a glass of wine and sit down and get it done. But everyone should be in there because, each provider is really responsible for their coding. And
Hmm.
you want to make sure that you're involved a little bit as a provider into what is being billed out. That's the unfortunate thing that I've seen in medical billing is, oh, if you code it this way, it's covered. Well, no, we're going to code what we did, why
Hmm.
we did it, and if it's covered benefit, it is.
Yeah.
And you see in dentistry, you see it a lot with like the SRP versus Profi, oh, well, we can't, they know that. But yet when they take a medical course, they say, well, if we code it this way, it's covered. No, you
Yeah.
can't code a bone graft with, for socket preservation or at the time of an implant as if it were a bone graft to replace, a large part of someone's mandible that was lost due to a slip
Oh
start,
gosh. Yeah.
cancer.
Wow.
So you've got to know what you're doing, do it properly. Don't code say, oh, I'm excited to get my first benefits. Like I said on
Hmm.
sleep services, if the diagnosis isn't sleep apnea, they're not going to get benefits.
Yeah.
Period. You're still going to improve their life,
Right. But you
but
have to
it's
have
going to
those
be out of
steps in
pocket.
place.
Mhm.
Yeah. Okay. So the group coaching piece, that's something that I wish I had had more of when I was starting out as a manager, just having that's why like when ADOM came along, like, thank God, you could reach out to other managers. But even so, one of the best things I've ever done in my career was I participated in little masterminds here and there. I've gotten groups of like-minded people together or been asked to be in a group and just sharing knowledge. They don't have to be long-term, but it's really nice to have that. So if any of you are listening and you're like, I want to take it to the next level, you can get your groups of people together, but the virtual coaching piece or group coaching specific to your classroom, I can't imagine that's got to be so popular because I feel like when I was medical billing for a brief period of time, I would have liked to have been able to run things off, up against a group and been like, okay, am I wrong in this? And that would have been, I would probably still, honestly, Leslie, if I had the opportunity, I would probably be okay medical billing back then, but I was so nervous I was getting it wrong and I had nobody to talk to about it.
Right.
So what's one of those group coaching calls like? What is usually happening in there?
To first go to why we have group coaching is you can take a day and a half course and you don't know what questions to ask.
Right.
It's
Yes.
when you get something 45 days later that, this
That's
question came up.
that's
So that's
exactly what
why.
happened. That's exactly what happened. I took a course and then I got back to the office and I was like, what do these words mean again? Yeah.
Yes, yes, you're kind of on like this overload. But the group coaching calls will just allow people to learn from other people because, it is regional because Medicare is regional, your local coverage determination versus national, et cetera. So you have these jurisdictions that, the payers will do one thing here and not in another.
Oh,
And
wait a
so,
second. Before you get into that,
yeah,
then let me just something important. Should they reach out and already know where their MAC is? And can you explain what that is? So that is that something they should already know? Like prep yourself for medical billing, even if you're not doing it now. Get credentialed, you recommend,
mhm.
and then know who your MAC is. Is that
Well, that's helpful because even if
okay?
you're not filing a lot of Medicare. Medicare tends to be the ones that set the rules, and then eventually it all trickles down to all the other payers.
Okay.
So knowing, you can just search, for your MAC, but there's really 4 jurisdictions for that.
What does MAC stand for? I forget. I don't think I've known what it stands for in years. I can Google it while you're talking.
It's a manager. It's the administration.
Oh, Medicare Administrative
Contractor.
Yes. Okay.
Yes.
And
Yay!
No, and so people, if you're like, well, why am I listening to you guys? You guys didn't even know what it was. When you use an acronym for so long.
Yeah, just like HCPCS. Yeah, it's like, healthcare procedural,
Exactly. So my MAC in Virginia, it may be different than yours in Indiana.
Right, especially on the other coast. But yes, so you all have your individual contractor for your area, Medicare, administrative contractor. There we go. And it's not that all payers will follow that. So, not to get into too much detail, but you have your Medicare that pays 80%, and then you have a supplement that would just automatically pay the other 20% because Medicare's approved it. But then there's plans that are like you retire from Chrysler, you have it's not just what Medicare covers, it also has additional benefits. It's still an insurance company on its own. Okay. So it doesn't mean that once you hit 65, it's only going to be what Medicare covers. No, there's other plans out there in addition to the supplements. But as far as getting to know what is covered in your area, and I was saying it was kind of like the trickle effect. And I'm trying to get back to the original question.
Oh yeah, no, I know. This is what we do. This is what you and I do. We just go off topic. Go ahead. Sorry.
Oh no. The actual virtual coaching just lets you communicate with each other. Okay, here's what I'm seeing in this area. What do you see in this area? What I find that people do wrong, for instance, I even worked for an oral surgeon. He said, well, we can't do a soft tissue biopsy on a Medicare patient the same day. And I'm like, well, I'm curious, why do you feel that? Mm-hmm. And it was because he said, well, I won't get paid for my exam. And it's like, well, you're not using the modifier that was to let Medicare know the decision for surgery was made that day. And you can use that modifier because that's true. And then they will pay for the exam the same day because you have a global period. So for instance, for frenectomy, it may be a 7-day global period. And that includes the day prior, because when you think about it, if you're going to go have a procedure like a gallbladder removed, you're going to have your evaluation beforehand, right. Then you're going to be admitted and you're going to be taken care of. Where with a soft tissue biopsy in this example, the patient was a new patient that day. My decision to make that procedure was that day. I'm going to communicate by using this modifier. Okay. Then I have, 7 days where I'm not going to charge them for post-op care, where sleep service is more like a 90-day. It's once you've taken the classes, it's public knowledge as to what the global period is for that procedure code. So, it's just a matter of knowing what you're doing. So this doctor was like, wow, because who wants to bring a 90-year-old lady back that's already takes her an all-day thing just to get to your office when you're able to do it that day. You just have to know that there are modifiers that say, okay, in this instance, it was the decision to remove that little area on her lip today.
He must have been thrilled to know that. Like he was like, what? Why didn't anyone tell me this stuff?
Yeah, especially for the patients, because those are the ones that, you've got son or daughter taking off work to bring them in. And it's a big inconvenience. Okay.
So you learn that stuff like when you're kind of bouncing ideas around off of each other.
Exactly. And so, that may be a question that even if you took the class, you might think, oh, don't remember this part. Or a lot of them will bring, I do a HIPAA with everybody just because somebody will, bring something that they want us to look at I definitely want it to be to where you don't have the patient or the provider information on there, but they'll bring something, they'll say, what does this mean? And Teresa, back in the day, I'd done trauma billing for years, and they did not have qualifiers back in the 80s. And I still remember the first insurance company that said, well, what's the qualifier? And I said, well, do you mean the modifier? I mean, things change, right? Yeah. And that's where the classes, because you get the ongoing support, that's where it's nice, because if anything changes, I let you know, hey, there's something new in our field, or, there's a new system. I already have ICD-10 and ICD-11 mapped out.
Oh, wow.
COVID killed 11, and I don't think there's no deadline on it now. But I've already got that mapped out because it's such a different system than ICD-10. When you're working in private practice, you've got so many hats that you're wearing and you're multitasking all day. You don't have time to look out for these things. And that's what you do for all of your listeners. Is it's like, okay, I'll keep my pulse on all these areas so that you don't have to. And then we'll take a deep dive into it when that occurs. So that's why I think, for instance, an oral surgeon called me, and the reason she likes my classes is because she's been in practice 2 years. And she said, I hire from general dentistry typically, and they know everything except for medical billing. And I'm not even qualified to teach them that. So it's not like I can sit down with them.
Yeah.
So, once you've had the year of courses, which are still going to be applicable to you, you can still continue coaching at a lot, reduced cost for that reason. So I can train all your new team members as you add providers or change, that dynamics in the office. So.
Yeah. And I found that's, I have the online dental insurance class. I found that I hear it stinks, but our industry has turnover. And, the doctor's like, I'm so thankful that now I can just say, go take the class. I don't have to hire you again to do a virtual session, which is actually why I created the class. Because, honestly, I was training doctors, the same doctor's office, maybe like every year, every 2 years, because they had turnover. And I felt bad, like, man, I'm charging you again. I mean, the money's good, but I'm charging you again. Like, why don't I do this? And that's really what started it. And before you set this up, this is something you and I had talked about was, we need to be able to teach more people than what we can actually physically either get online or be in person. Because like you said, you went to the University of Michigan, right? And you have, I don't know, maybe you have 50, 60 people, say, for example, you've really dedicated that time for 50, 60 people, putting it out online and they can absorb it at their time is you can impact hundreds of people. To me, that's the beauty now of where we are with virtual learning. And so I'm glad you have that.
Watch and learn style, true. And
yeah.
just like your dental revenue network,
yeah,
I love that.
Thank you.
Because,
Yeah.
The business side of that, I mean, it took me years to develop my, outsourcing company. And now for knowing that I have someone like yourself keeping your pulse on the regulations and laws and things like that, it's invaluable. I mean, it's something that I really cherish. So,
thank you.
It's the same thing.
And I haven't even really put it out. So there might actually be some listeners that are like, what is she talking about? I just launched a membership called Dental Revenue Network. And it started out for dental billing company owners to keep them up to speed because, you guys are running a small business with staff and all I do is keep up with policy and procedure. So you guys need what I need. And I don't want to do necessarily with the staff like what you guys do. And so it was a real good kind of marriage between those industries. And so I started the membership for that. And now I created a sub tier for billers. So if you are a dental biller or work for a dental billing company, now they can join. But I just want to be clear that this is not the place to come to say, what's the code for, or, how do I calculate a deductible? This is where it's really the business of insurance and how to be a better biller and understand revenue cycle. But yeah, no, you're an invaluable member of it because there's a handful of people in there that know medical billing really well. And it's so nice to have a resource, honestly, that, where I can say, hey, where's Leslie? Where's Christine? Where's, those kind of people. And I'm excited that you do the class with the virtual coaching, because that's something that my dental billing class doesn't have. We're online, right? And they can do that. And they can, leave comments and ask, but the virtual coaching for medical billing, I can't imagine a place where anything's more needed than that, because it is so, until your mind actually wraps around it, it's so out there, right? So you've been able to translate that down to quite a few people.
In order for you to be successful, you need ongoing support. I really do firmly believe that, because it's so upsetting to me when they say, oh, I've tried that and it didn't work. Well, that's typically where it fails. It's an ongoing support.
Well, and one thing about medical billing, and again, we've talked about this offline, you have to keep up with it a lot more actually than with dental billing. So how often do things change as far
quarterly?
Quarterly.
Now,
wow.
Like, for instance, there's difference for your ICD-10s. COVID is a perfect example. There were not COVID diagnosis codes. So it's not like I'm going to wait a year to give you COVID, diagnosis codes. And actually, one of my sessions is about vaccinations and things like that, because a lot of dentists are starting to do vaccinations. So that's a good example. It's like, okay, here, alert, we've got our new codes. Here they are. But for the most part, quarterly, you want to make sure you keep up to date with it. And that's where I just, hey, alert, we've got some new coding systems here. They're added to the online courses. And then also, Teresa, I think another important thing is, if there's an area in the classes, which my goodness, if you look at the procedures that are covered, I'd be surprised. But if there is an area that it's like, okay, I really feel this is missing, then the virtual classes, the coaching will say, hey, what is your experience in this area? And if I don't know, that gives me another couple of weeks to do the research and get the material and do a new video and upload it for people.
Oh, for sure.
Because that's how we all work together. I mean, my classes are like, you just join my practice and I'm sitting right beside you teaching you. I mean, you'll get sick of looking at my face. I know I have. It's like, okay, wait, back off my face a little bit. But for the most part, it's just, I want you to succeed and I want the patients to get the benefits they're entitled to. I don't want somebody saying, oh yeah, we don't bill medical, or, oh no, that's not covered, when they haven't attempted. And I will try to make this super quick. I was in a post office, I had an implant logo on my shirt, and the lady said, I know what those are. My daughter had 4. So I'm like, yeah, ding, those are congenitally missing canines. She goes, yep, and so I said, well, did your medical insurance cover it? No, the dental office said, no, this is dental in nature. I said, come on under your lunch hour. Let's just call your plan. 75% coverage, implant, abutments, crown, pre-op pano, post-op pano, guide, the entire diagnosis was covered. So I never had to wait in line again at the post office.
That's a great story.
It's true.
Wow.
It's who loses and who's in the high rises. Here in Indiana, we have a lot of Blue Cross Blue Shield, Anthem, it's our largest employer. You've got these high rises, and it's like, what benefits, who won in that? The patient to get the benefits they're entitled to. The employer, I knew where she worked. They're paying for benefits that she did not get. So, it's just, I'm very passionate about it, as you can tell.
Yeah, no, and I love that. And so she was able to so did you have to help that office to figure stuff out? Yeah. Okay.
Yeah. And even on my insurance billing outsourcing, it's not what I'd love to call it, but it's a buy now button where a patient can go on there and say, hey, my provider's not filing this for me. So we get permission from the provider and we file the claim for them. That's because I am passionate about making sure patients get benefits they're entitled to.
That's a great service, Leslie. I can't imagine, gosh, if word got out about that, I think more patients would take you up on that because they just don't know that.
Yeah, well, there's one frenectomy office. We just print up some business cards and they just hand it to them, say, hey, if you want to file medical, here's your card. And then they just go on the portal. And on our OMT, our hygienists that have the oromaxillofacial, therapy, we do that for them too, where we just direct bill from the patient to the payer.
That's great. I had no idea. Okay. Wow. All right. So how can they find you? So it's Dental Classroom, but how can they find you and connect with you should they need to?
Yes. My email is leslie@dentalclassroomonline.com because I like to make things long. Dentalclassroomonline.com, where they can visit the website. You can schedule a discovery call with me and I'd be happy to do it. But that is really the best way to reach me, Teresa.
Good. Yeah. And every now and then you're out there speaking, and like you said, to this University of Michigan place. And anytime you can catch Leslie, you want to do that.
And listeners get a 10% discount. So just throw that up.
Thank you. I'll put that in the show notes. And awesome. I'm just excited because when there's an area that I know there's a huge need and I'm not good at it, it's so hard to find good, trusted resources. So I want to thank you for being one of those for years for me. So I hope that this is just super successful and doors get blown off and stuff because it's so needed. And people in my classes, when I say, look, you guys got to get comfortable with medical, you can see there's fear there. So I'm glad you're there to hold their hand during it.
And, the people that have really set us all up, like Christine Taxon and stuff, that have really put a passion into this for years, a shout out to all of them as well, because, it is something that has crossed over in our industry and we must know.
Yeah, I can't ignore it anymore. It's in my classes now. So, but all right. Well, thank you so much, Leslie. And we'll put all of the information, dear listeners, at the bottom of the show notes so you can find out more about Dental Classroom and connect with her, find her on LinkedIn, social media, and all of that. And again, dear listeners, I always, always appreciate that you spend your time with us. Thank you.
Thank you all. Thank you, Teresa.
Sure.
We're all super busy, so thank you for making time for me today. The show notes will have any links that we referenced in the episode. You can also find links for my book, events, and my online insurance course, Dental Insurance Design and Management. I speak often around the country on management and insurance issues. Come hang out with me in one of my classes. I promise you'll laugh and learn.